chat and stuff. Well, let's get started. I'm going to introduce our guest for today. Sort of, I feel like we have a TV show now, and we're going to have a little discussion today. This is Dr. Lee. We're broadcasting from Comer Children's Hospital, right? And we're going to be talking a little bit today about some work that's currently happening in our state around children who have been lead poisoned. Specifically in early intervention, what we have going on is that a work group was put together through the Council of Early Intervention to look at making children who are lead exposed automatically eligible to receive early intervention services. And so it's split up into two work groups. There's one group to determine what lead level we should be determining as automatically eligible, so above a certain what is it, decimals or
micrograms per deciliter.
Yeah, micrograms per deciliter is the way they measure it, right? When they do the blood test, after a certain level, then that would trigger an automatic early intervention eligibility. And then the second work group, which I'm on and representing all of you guys, is to determine what services would be best appropriate to address the needs of these children, to get some recommendations. And so we're going to have a little discussion about that today. Hi, Shauna. Thanks for joining us. And I want to get your guys' input and feedback because I'll be going to this meeting, I think is on March 23rd. And and we'll be able to provide some of the feedback that we get from you guys today in terms of types of services and any comments or questions you guys may have. We may be able to kind of share that back to the work group. Now, this work group kind of came as a result of, as you guys might have seen in some of my posts that I posted about this upcoming Facebook event, they came as a result of the governor's children's cabinet making or addressing lead as one of the top 3 priorities. And so that's kind of where they kind of stemmed from, us kind of looking at addressing children who have been lead poisoned through the early intervention program. So, Dr. Lee, if you want to tell us a little bit about kind of the process of what goes on to kind of identify lead and some of the things we might be able to kind of notice in kids.
Perfect. Hi, thank you guys for joining us. It's a pleasure to be with you. My name is Dr. Lee. I'm a second-year pediatric resident at the University of Chicago, which is, for some of you not in the city, it's on the south side of Chicago, and we serve a predominantly, I would say, low-income primary care patient body. And so this is something that we see too frequently, lead poisoning. And so just to give you guys a little bit of background information about it for those of you who don't have kids or maybe have never seen lead exposure. So usually kids are screened at first. We screen all children at 9 months of age. And so the cutoff is basically less than 3 in terms of what is considered normal. But to be honest, no level of lead is normal. You shouldn't have any lead in your body, period. And so if any of you all who are joining us have been or are tested right now, you probably would have a level that's 0 or at most 1. And some of the places that you can get exposed is through water, for those who maybe have older lead pipes, or through paint or through the soil. So it's more relevant for kids because, I'm assuming you all aren't eating soil or paint, but children can get access to that. And the thing that we're starting to see is that, and so just to give you a little bit more medical reference, your lead levels can get as high as 45 without you having any medical intervention. So let's say you came into my clinic and you're a child and your lead level is supposed to be 0, but we find a lead level of, let's say, 30, you actually still wouldn't get any medical intervention and we would still watch. The level that you get medical intervention through oral medications or IV medications is at 45. So that's much, much, much higher. And so if you're at those levels, then, you're talking about a different patient population. That's usually a very acute exposure. That's usually something that doesn't happen maybe over a long time, but maybe a kid just really ate like chips of paint that day, or got access to it's usually the pain that we see it in.
So at that level, do they start, in terms of treatment, when they're giving, oral, are they chelating to get the metals out, or what is it that's happening?
Exactly. So at that level, it can be very toxic, and because it crosses the blood-brain barrier, you can have seizures and things like that. So what you're doing is, through oral medication, you can bind it in your body, or if it's higher, you can give IV, so you bind it in the blood.
Okay.
And so you're just trying to bind it so that you can excrete it from your body.
Got it. Okay.
Go ahead.
No, go ahead. So then, what about for the kids then that we see at lower levels?
Exactly, and this is kind of where the work group comes in, because there are more studies coming out about lead levels even as low as 2 having long-term effects on children. And so if you think about the fact that we don't do anything till as a medical community till it's 45, there's many children in between that range of 0 and 45 that don't require inpatient hospitalization, but now we're starting to find more and more studies that are saying chronic lead exposure, even levels at 3, 4, as low as 2, they're having long-term ramifications such as education deficits, language, speech, things like that we'll talk about a little bit more.
Okay. So again, that kind of gives you a little bit of background as to why we're seeing some of or why this work group is kind of initiating, and what the work is kind of the work ahead of us, right? And so for this group, what we really wanted to do is kind of talk a little bit more about what are all those things that you're going to see with a children who is lead poisoned, and then also for us to begin to think about how can we as developmental therapists, or even thinking broader as early interventionists, so thinking about some of our colleagues, speech, OT, PT, how can we contribute to to help minimize the effects of lead poisoning that may be seen in their delays. So a couple comments. Hi, Ellen. Good to see you. And Amy's asking, is screening at 9 months universal across Illinois?
To my understanding, it is. So what you do at 9 months for all kids, I've seen it as early as 6 months, but it's pretty standard to be 9 months, where you do a routine blood exam, which includes what's called a complete blood count. So you see their hemoglobin, and then you do a lead level. That is fairly standard across pretty much the country, and so I would say it would be that way here in Illinois as well.
Okay. So in terms of what we may see, first of all, is anybody out there that's kind of watching us had any experience with working with a child who has, whether it's already been referred to early intervention and later you find out is been lead poisoned, or any children that you guys have experience with lead poisoning at all? If you do, give us a quick little like so we know that you have, just to get a general idea of people out there. And if that's okay too. I think it's something that we, in my time of providing services, I can think of maybe a handful, if that, of providing 20 years of service, that I can kind of say, yeah, well, I knew either coming in they were lead poisoned, or afterwards we found out that once they got some blood work and they were already getting services, did.
Yeah, and it would make sense that many of you have not worked with any child who has had lead exposure, because unfortunately for these low levels, and even I have a patient whose levels were chronically in the 20s, which again is very high, but showed absolutely no delays. And so because when I was seeing this patient who was still about 15, 18 months, and we're continuing to follow this patient, but you may not see a lot of these effects till they go to preschool, or they're in elementary school, or even later, that they're finding that when they track these kids over a longer period, they will start to show subtle or even more really prominent delays, usually, like I said, in education, focus, like more executive function kind of tasks.
So let's talk about some of the things that we might see in those children, given some of the current research we have about things that are kind of show up either at preschool or afterwards. What are some of the things that we've seen?
Yeah, so acute exposure, you can see abdominal pain, you can see kind of, it can deposit in your bones, and you can see joint pain, constipation, you can see altered mental status where they're just not acting the same, or like I said, in really high level seizures. But that's more on the medical side. That's really what you all as developmental therapists wouldn't see. What you all would see, again, is there's a lot of work correlating lead toxicity with attention deficit disorder. And so as you can imagine, that is something that will affect children for all of their education and going forward, even with work. They're finding a lot of speech and language delay, so they're either delayed in learning speech, or have a limited vocabulary, or have trouble learning language. There's often, sometimes this is more rare, but you can see motor disabilities. So they have a limp, or they aren't meeting their motor milestones, so they're not walking on time, or they're not able to use their limbs as easily as other children their age. But really the majority of the studies that have been done is really on the intellectual level. So when they compare children who have no lead exposure, which is normal, versus children with lead exposure, they're seeing that they, graduate school at a lower rate, or they have lower test scores, or they have lower educational achievement. And so that's the big realm that we're seeing this play out.
And then I think we're also seeing some things around behavior as well. Some difficulties with, aggressiveness, impulsivity, some of those type of things that we're seeing, which sometimes I think for us, especially in the earlier years of development, when we're seeing kind of a combination of inattentiveness, maybe some type of aggressive behavior or impulsivity, often our minds go to difficulties with sensory processing, and we tend to think a lot about those type of things. So some of these things we might see kind of in a mild case, in the early years that may not. Typically, when we do initial evaluations to determine eligibility, we may not right away determine a child eligible, or we may not see even any of these delays right off the bat. But if we find that they have already been lead exposed, then again, through this work, it might be an opportunity for us to begin to intervene early to try and see if we can mitigate the effects that start happening in the preschool years.
Yeah, and so I know Benny and I were having this conversation prior to starting, but lead toxicity is something like a lot of health disparities. It disproportionately affects people who live in low-income housing, and often people of color. And that's been across the country that they found that, because a lot of times you're getting exposed through your pipes from old homes with old pipes, or through paint from old homes. And so right now I think it's even more important that we take a stance and we allow children with lead toxicity to have services, because a lot of these children, even without lead toxicity, are at a disadvantage to begin with, right? A lot of them, a lot of our patients live in a community where there's a lot of violence, where there are failing schools, where there aren't adequate places for them to buy healthy foods. And so if you add on top of all of that adversity that our patients have to overcome, the fact that many have lead toxicity or high lead exposure, it's just adding another hurdle that they need to overcome in order to just keep up with children who come from, communities of higher income, or communities where they have no lead exposure. And so I think that's why our work is even more important.
Yeah, I think as developmental therapists, I think who understand kind of what are the critical things that children have to have in order to kind of foster their development, in order to kind of really get them going. We know that, having good, solid, interactions and relationships and opportunities for experiences really kind of take advantage of all of the brain growth that's happening in the 0 to 3 years. And so, it's another thing to kind of keep in mind that, we've seen that as well, where we have like children who are at risk, right? Because of their, the environments that they're in, some of the limited opportunities they may have. And so, so again, I want to hear from you guys as developmental therapists. How can we be able to kind of, keeping those two things in mind, how can we as developmental therapists help, those children who have limited opportunities, as well as, those children that kind of go hand in hand with being lead exposed and may have an opportunity for, be predisposed to more delays. So go ahead and let us know about some of your comments here. I see, yes. Hi Susan, you've joined, and Flor, Kristen, can you talk more about the implications for hearing loss?
Yeah, that's a good question. So the problem with lead is that in high levels, it deposits in many places. Like I said, it can deposit in the bones, but the big issue is that it crosses. Your body has this nice regulatory system where it doesn't allow a lot of things to go into the brain, right? So, I mean, that's a great safety mechanism that our brain has, that, a lot of substances that are in our blood or body, it can't cross this, what's called the blood-brain barrier, but lead can cross that. And so when it gets into the brain, that's important for hearing, that's important for vision. I mean, your brain controls all that function. And so it has been found that at higher levels, you can have hearing loss, you can have vision issues. It really is a wide array of physical manifestations such as that. But there isn't as much because those are usually at higher levels and usually for longer periods. And I think those are things that we watch more carefully. I think the really interesting data is even at low levels, like levels that we thought as a medical community was acceptable, we're starting to see a lot more negative side effects. And that relates more to the things that Benny and I were talking about: behavior, speech, language, education, and things like that.
Yeah, so I think we can see, hi Michelle, thanks for joining us. I think we definitely have a lot of good literature that's telling us kind of the effects and impacts of lead poisoning, and so, which is why there's so much information about prevention now, right? And some of the things that we recently saw with the issue with the water in Michigan kind of really brought this again to light a little bit, and we're finding that here in Illinois we have some similar issues with our water and things like that, which again was why the governor made this kind of a priority here in Illinois. What I found as I started kind of looking through the literature and kind of trying to educate myself about it and trying to find a little bit more information, there's not a whole lot of literature around kind of treatment outside of the medical treatment. When we try and look at kind of the therapeutic interventions that may be helpful, we don't have a lot. So in that sense, there's not a lot of information that says what's most effective, what impact can we have. But it is an exciting time because we can be part of that process to kind of begin to build that literature through our work. So I'm excited about the opportunity there for us to be able to kind of contribute to that work. Ellen had a good question here. Let's see. So many of the children we see have language and cognitive delays and impulsivity. How do we determine if these are related to lead exposure versus other causes?
Yeah, that's a very, very difficult question because Benny and I were having this exact conversation, but a lot of the patients that are affected by lead toxicity come, again, from low-income communities. As many of you, if you saw the crisis in Flint, a lot of the people that were affected by the lead toxicity there were people of color, people from low-income housing, people from under-resourced communities. And so I have patients, again, that I serve who don't have any lead toxicity and have these same delays, right? And so in terms of language development, right, there are tons of studies that show that children who come from a low-income household will know hundreds of fewer words than someone who comes from a high-income household. So there are a lot of studies like that. And so it is difficult right now, and I think this is something that we really have to figure out as a medical community and as a therapy community. How do you separate that, right? Because we can't do a study where we get 3 children and we expose one child to a lead level of 10 and one child to a lead level of 5 and one child to a lead level of 0 and then see how they develop. And so right now, I think that is difficult to kind of separate. Is it their environment, or is it really the pathophysiology behind lead toxicity? And I would say that it's both. And I think that's why it's even more important that we give these children as much support as we can. But that's a great question.
Yeah. Amy Kokorikis had a question about other states, I think, and Are we aware of any other states that are focusing on this
Yep.
population in their early intervention systems?
That's a great question, and so that's part of the work that we've done, and we found that there's about 15 to 20 states that do automatic eligibility, and they range in terms of level. The lowest level that I'm looking at here is 5, Massachusetts, and they're often one of the kind of pioneers in like public health, but their level is 5. So if you have any exposure over 5, you get an automatic early intervention referral. But I see some states here that as high as 25, like in Connecticut. But that's also actually only about 15 states that even have an automatic referral. And so the rest of the states, including Illinois, we don't. And so, some of our children that we've had lead toxicity, we've had to try and figure out how do we, what diagnosis do we use to get them early intervention? And like the patient that I was talking about, whose level's in the 20s, I was having a little bit of trouble figuring out, because he didn't have delays at that time, what can I put as the diagnosis for a EI referral?
And I think, and some of the work we've been, again, prepping to kind of have at this work group, we did find that I think there was one state, at least one state, which in the language for automatic eligibility also included language in regards to providing services despite the child not yet showing delays. So that's another thing that I think we can think about. What do all children need to be able to develop? We know that, again, in these early years, children are developing brand new neurons and connections in the brain at a rate about, I think, like 700 a minute or something like that, or a second. It's an enormous amount. All of the experiences. I mean, if you think about these little children, as you watch them kind of interacting with the world, right, picking up something and exploring it for the first time, I mean, the brain is just kind of fluttering and growing and all those type of things. So we have an opportunity to, through the social interactions that are happening with parents, by helping support parents and having nourishing interactions with their kids, we can help overcome a whole host of issues. So I think that there's another opportunity there for us as early interventionists, or even us as developmental therapists, by coming in and educating the parents about what those experiences are, and just give some general education about how they actually help their children grow and develop, can really help these children that are probably lead poisoned. We have a couple other questions. Keep them coming. This is a really good discussion. I want to have all of your guys' input so we can take it back to the work group. Susan Connor had a great discussion wondering how we can think about supporting families with kids with lead exposure if they have not yet showing obvious signs of developmental delays or challenges with behavior, etc., in the birth to 3 range. Yeah, I mean, it's something we were just talking about with that, so I think it's a great point. I mean, and I'd like to hear from you guys that are watching, too. How are some of the ways that you guys think that we may be able to support these children and these families prior to them showing delays? Do you guys think that's possible? What can we as developmental therapists contribute? So go ahead and add in your comments there, your ideas, or concerns or questions you have, so we can bring it back to the group. Flores said, what do we know about the toxicity in utero, a situation where the mother may be exposed through environmental causes?
That's a great question, and it is something that we have to think about. Lead crosses the placenta. There are, again, a few things that can go from mother to baby in utero. Lead is one of them, and so it often correlates. So if your if the mother's lead level is 10 or 15, and the child who is born will often have a lead level around that same. So it does cross the placenta, and then in extreme cases, it can cause miscarriage. It can cause really low birth weight. It can cause prematurity, and so it does affect pregnant women and their children as well.
Shauna had a question that kind of follows up with that. Can the side effects of lead poisoning be hereditary? So I'm assuming she's asking, can it be passed on once you have lead poisoning onto your children or those type of things?
Yeah, no, so lead is something, so an easy way to describe lead is, for example, let's say someone is poisoned or they overdose on opiates or they overdose on Tylenol. So those are things that happen because a person consumed those things or took those things. And so it wouldn't be hereditary in the sense that, let's say you are someone who has had lead exposure early on in your life, and then you have kids. If you don't have high lead exposure at the time of pregnancy or during the time that you conceive, then it shouldn't be passed on to your kids. If you're living in the same environment, then you're probably going to have your kids have the same lead exposure that you did, because you probably got it through water or paint or soil. If you're in the same place, your children will probably do the same thing, but it's not something that is passed on in that way.
So great questions, guys. Keep them coming. I'm going to keep looking at these comments. I apologize. You get extreme Benny Zoom every time I come in, because when the iPad is on the table there, and you can only do this from an iPad. You can't do it from a laptop, unfortunately.
Oh, really?
Yeah, it doesn't work that way. And so every time I'm looking for the comments, because as I get older, my vision goes. I got to get closer here. So Kristen has a comment that says, since the medical community knows that low-income families are more susceptible to high levels, what's the medical community's position on testing this population more regularly beyond the 9 months check?
Yeah, so that is a good question, and I think at our clinic, like I said, we serve almost all people from low-income families. And so we are, I would say, more vigilant about checking lead. And so, for example, with the patient that I had with higher lead levels, we'll have much more frequent follow-up. In their case, we did an X-ray to see if the child had consumed a lead chip you could see if they consume like a large amount of lead. You could actually see it on X-ray. So we sent the child for an X-ray, and so I would say because we have much more experience with elevated lead, unfortunately, we're much more acute and adept at following up. But at the same time, our families often come from kind of situations that are tough, such as transportation, where transportation is difficult, or taking off 2 days a week to come to the doctor to have lead levels checked is very difficult. And so it's always this fine balance between understanding the needs of the child and the family, as well as understanding like what we need to do as a medical community.
Great. We got another great comment here, and we'd like some more feedback about these type of things. Amy said, DTs can offer families developmental guidance and proactive support similar to preventive home visiting practices for at-risk and early Head Start or healthy families. I think that's a great thing for us to consider of what we as developmental therapists can do to contribute. And I think it'd be helpful too. Again, I'd like to hear from you guys and comment on, what do you guys typically do when you guys, let's say, do an evaluation and see a child who may be more at risk for things, but isn't yet necessarily showing a developmental delay, or may even have a minor delay. Maybe we're not getting to that full 30% that says, hey, it's ready to give services. Do you guys, in some opportunities, kind of say, we're going to make this child eligible because there's multiple at-risk factors here, and we write a clinical judgment statement, and we want to go ahead and provide some type of support. I'd like to hear from you guys, what kind of level of support do you guys think would be helpful? Are we thinking like a child who may not show delays yet, but has lead poisoning that's been determined at whatever level, 5 or higher, or whatever's determined through the work group? Would you guys think like maybe developmental therapy once a month would be enough to provide some family support, or twice a month? Or are we thinking something like a weekly visit? What are you guys thinking in terms of the type of level of support and what type of information we should be giving and sharing with families? That'd be really helpful for us to kind of bring back to the group. All right, let me lean in again for some comments and questions. Ellen says, once a child is diagnosed with lead in their systems, what is being done to reduce future exposure? Is the health department getting involved to figure out where the child is getting exposed?
Those are great questions. And so some of the things that we do, again, like I said earlier, if it's less than 45, there is no medical intervention, and that's through various studies from the medical side that they haven't shown to have benefits. But some things that you can do is put them on iron. That often helps because iron competes with lead in terms of being in the blood system, and so you really want to make sure they're on a good amount of iron, and a lot of kids are anyway. But other things that we do is just routine surveillance. And then the hardest part, and this is exactly what we're struggling with, and this is why I keep mentioning, a lot of the families that deal with lead toxicity have a host of other issues, okay? And so I'm going to keep using the one child I had in the 20s, because that's a very high level, and that's the only child I've had in the 20s. But they found that it was the house was basically not up to code in terms of lead, and so the child was eating lead, and that child was eating the paint, and that's often kids. If it's, I mean, that's kids. Any kind of child would do that, but. And so we found that, and then we connected them with the Department of Health, I believe, and who had someone come and talk to the landlord, and we got legal services involved. But it is a very, very long, drawn-out process. And for a lot of our families, they don't have an alternative housing, right? So they don't have an option of, oh, let me go live with this person in the time being, or that person, or this family member. And so in their case, they just had to continue to live in that environment until things were sorted out. And so it's something that is very difficult on the legal side as well, to try and figure out how to remove them from this environment, because again, a lot of our families can't just, oh, okay, this is not safe housing, let me go find other housing. And so that is something that I think really spurred this whole process of working with lawyers, right, from the legal side, working with therapists and physicians to kind of like full circle try and deal with this issue of lead toxicity.
Mm-hmm. Hi, I'm going to, I hope I don't mess up your name, Aras, I think it is. Welcome. Thank you for joining us. Again, feel free to kind of comment below on some other questions you guys may have, or thoughts that we can kind of bring in terms of providing therapy services to these children. Because again, we want to kind of talk a little bit about the treatment options for kids from a therapeutic standpoint when we come back to this work group.
And one thing that will be helpful for us as physicians, and maybe Benny, you can speak about this as well, but we don't actually know what happened when we refer to early intervention. We had a lecture on it was an early intervention coordinator, so it wasn't specifically developmental therapy, came and spoke to us about what happens next, what kind of services are offered. But what does my patient go through when, and in particular, of course, if there's motor delay, we know like you work on that motor delay. If they're not using their left side, you work on that. But it would be really helpful for me to know if you have a child who isn't showing delay, like you said, but is high risk, whether from lead exposure or other reasons. What are the things that you guys do in that first visit and then going forward?
I think that's a great question. We can. Anytime I can come talk to your group and a little bit about kind of the developmental therapy perspective of what we do, because that's another thing that I think a lot of doctors are familiar with, what a speech therapist does, a physical therapist does, those type of things. But developmental therapy for most people can be kind of like, well, what exactly do you do? And so, but through the early intervention process, once we get a referral, we'll go through a set of evaluations. They're going to provide a global evaluation, which is typically performed by a developmental therapist to check all areas of development. And then the area of specialty that you may be referring for. So if there is a concern with speech, then you're going to have the speech therapist come in and the developmental therapist. Or if there is a behavior concern, there may be, a psych or social work evaluation of a developmental therapist. And the goal there is to have two people that agree whether or not the child has at least a 30% delay in one or more areas to get services. And so once we get that kind of going, let's say the child does not have a delay. The nice thing about early intervention is that we're also well connected with other home visiting programs and things that are happening that we can send referrals for other type of things. So things like Healthy Families or Parents as Teachers programs that we can kind of send referrals to, where they can come in and do some home visiting because they're more at risk for things, and also to provide some type of level of support there and education for parents, But if the need is for some kind of therapeutic intervention, then we'll provide those services, whether it's on like I said, kind of a monitoring basis, and it's like a once a month type thing, or just frequent evaluations. Sometimes we provide just service coordination, where the service coordinator is involved in keeping apprised of the case, answering any questions the family may have, and bringing them resources. to other times, again, something like developmental therapy, we're going to be working on cognition, attention, regulation, some of those type of things to kind of look at the whole perspective of learning. Essentially, we're like the teachers, for early intervention, right? And so teachers for parents, and then education and teachers for kids as well. And so, so we can provide all those type of supports. Let's see, we got some other great questions here and comments. Kristen says, I think it depends on the family, their priorities, needs, resources, etc. But we as early interventionists can certainly support these families, particularly with typical development milestones, among other things, I think. So yeah, that's a great perspective, Kristen. I think that we as developmental therapists are definitely well equipped to be able to provide that information and support about the big range of development, right? With one person, we can kind of really understand, what's supposed to happen when and what type of activities will help, a child development. Susan said, Kristen, I think that's key, maintaining the individuality of the type of supports we provide by always going back to family priorities, concerns, etc. Prevention will be the focus for many of the children, I think. Which is a great point, and I think that brings up another good discussion, right? Is that when we have a child who may be lead exposed or poisoned, but isn't showing delays, what might be the priorities of a parent? Like, have you seen when parents come into you, let's say after they've been determined that they were lead exposed, do they then have questions or let's say kind of priorities? Well, I'm concerned about this, this, and this, and it might be because my child's lead exposed. Do you get that often, or?
Yeah, so I think twofold. I usually have two reactions. Number one, how did it happen? Mm-hmm. And so trying to talk about the things that you can prevent. So, are they putting things in their mouth? Where are they playing? And then so the type of home that they're in. So I think that's the first thing that we discuss. And then the second thing is, yes, they always ask about what does this mean, right, going forward? Or what are the side effects of this? Mm-hmm. And I think this is what becomes difficult because sometimes it's been difficult to convince our parents to even do early intervention because, again, they may not see delays at that time. Mm-hmm. So they may be meeting all milestones at that time and then not feel that they have to go through early intervention. Right. And through some families, in any community, even friends of mine, I think once you throw out that word early intervention, sometimes there's a taboo as if, oh no, my child doesn't need that. Like my child is quote unquote normal, and so I think some of that has even been a challenge. And I think so. It's kind of letting them know. First of all, trying to figure out the source, but secondly, just letting them know that these are services that are often preventive, and these are services that. Whether you are lead exposed or not can be beneficial to your child. Right. I think those are things that we usually have to kind of talk about.
Yeah, I think that's a really good point. It's one of the things that I wonder too is it comes with its own kind of connotation, right? Even I had a family call me recently. I actually sent me an email to my practice. Saying that their pediatrician referred them for speech, and it was a pretty lengthy email about talking about all the things that they've done to support their child. Why they're not overly concerned about the things that they're having with their kid, but they're just following up on a doctor's recommendation. And so I think the hopes is, that, okay, I'm going to get this evaluation done just to kind of appease my pediatrician, right? But I'm hoping I don't need any services, right? Because then that means that there's something seriously wrong with my child. And so again, I think when we talk in terms of kind of like priorities too, I think, we definitely want to keep that individualized piece of things because that's what makes early intervention so wonderful and unique in comparison to other services, is that we really are driven by the parents' individual needs or concerns, right? And there always is an option, and will continue to, even if somebody's automatically eligible, to not have to get services. They can say, you know what, I'm fine, thank you, and move on from there. But I wonder just that kind of piece of how many parents will have that perspective of kind of like, well, I'm not seeing any delays. This shouldn't be an issue. And so maybe if we work together between us, the early intervention community and our medical community to kind of provide some education about the potential of what may be happening for their child in the future and how some of the things they could take advantage of right now may help, decrease the need for services in the future.
And I think conversations like this have been helpful for me because, when we first started clinic, when I was first starting 2 years ago, when I would refer, I would have no idea really what that entails, who even pays for it, what do they come to your house, where do you guys meet, and so I wasn't able to have these really robust conversations with families. Now I'm much more comfortable. I've seen therapy sessions. I know much more about what happens, and I know that like initial evaluations mean that's it. Like sometimes you can have an evaluation and they find no deficits or nothing, and that's the last time you see them. And so I think it's important, like you said, that we kind of understand both perspectives. Like the therapy community understands where we're coming from and what numbers we use and why we refer, and then us as a medical community or from the physician side to understand what therapy entails, what developmental therapy sessions, what happens during that time.
Yeah, that could be really helpful. I think it's the beginning of a wonderful relationship between all of us, right? Let's see. I think we got some other great comments. Some CFCs have programs where pediatric residents go out and observe evaluations. We'd love to have you visit CFC 6 and see a team do an evaluation in a family's home. Yeah, that'd be great, I think. Right?
Yeah, please connect us, Benny, through email.
Yeah. We can get you guys kind of set up so you guys can come take a look at some of those to get some ideas of visits and kind of what it is. Because it's truly a unique thing, what we do in early intervention, because we're constantly building parent capacities. And so really the idea is, and I'm horrible at these idioms. You guys all know I'm horrible. It's because I spoke another language first. But it's like you teach the fisherman to fish or something like that instead of catching fish with a harpoon. I don't know, but it's something like that, right? Like instead of them having to do it on their own. Ellen says, I just looked at the eligibility criteria and maybe the state could add lead level over blank under the at-risk criteria. Example, parents with mental illness, parent under age 15, etc. Yeah, I think that's a great comment. We could definitely, add something like that. And I think it's something that's been considered to kind of add into that at-risk category, probably.
And I think that's kind of what the work group is doing, is trying to figure out like what category will we fit well under, and trying to have also so if you fit in that category, what services does that entail? And so I think that's kind of why we're putting all our heads together.
And it may be something where we're not overly prescriptive on the services and kind of saying like, that means that if you get this, if you have a lead level of whatever, 5 or whatever, that means you get ABC services. No, I think it might be able to kind of say like, hey, if you have this, you might want to consider these services. You have all the array of services available to you, like you've always had in early intervention, right? But you may want to consider these type of services. They may help you and kind of describe for parents a little bit what those are, and also give us guidance as therapists, right? Because oftentimes, we as therapists are going to get this information, and as a team, we're like, I don't know. We potentially could see from some of the early numbers we saw, somewhere between, I think, like 2,500 and 3,500 additional kids, I think, that we might kind of put into the system. So not a exorbitantly huge amount, but it's kind of like these, low incidence type things, like, when you have somebody who has a hearing loss or those type of things, let's say they have a hearing loss in one ear, so they're still hearing pretty good out of the other ear. What type of services might we want to consider? Are we going to do DTH or something else a little bit more DT hearing, that is, or something else a little bit more prescriptive, right? Let's say we have. Well, you get the idea. Like if we have some of those type of things, it's something to kind of give us as teams a starting point for some discussion, I think is what they're looking for. So you don't go in just kind of cold, not being able to kind of make some informed decisions as an IFSP team together with the parents.
Yeah, and then just to give numbers-wise, it depends on what cutoff you use, and I think based on other states, we probably would go for 10 as being the eligibility criteria. That's what most states seems like that they have, 10 or 15. And if we use 10 and above, in 2014, there were 1,328 children in Illinois with lead levels of 10 and above, and actually most of those were actually from the Chicagoland area.
Yeah, so that's another thing that I think we're going to probably see a little bit more. There, I think we also did see some areas as well as kind of like some rural areas that were saying that we might have an increase there as well. You know.
Yep, I think that's one group I think we often forget is the kind of rural poor even.
Yeah.
You know, a lot of times we think of like low income as an urban issue.
Right.
But there are a lot of communities in, you know, further suburbs downstate that have these exact same issues and have the exact same struggles in dealing with lead toxicity, old homes, pipes, etc.
Yeah. And I think you're also going to find that in some of the, you know, wealthy, you know, areas as well. Sometimes, I mean, you know, it's kind of interesting. But I was watching a little part of a documentary that's going to be coming out, I think, sometime soon in terms of lead toxicity and stuff. And there was families that also talked about. You tend to think about this in kind of the poor or rural areas, and they're like, and there is some that happens. So it's just about being well informed and being educated so that we kind of know how to be able to best support. Hi, Monica. I see you're on. What about? Oh, we got a little love up there. That's nice. So tell us other questions or insights you guys have. Ellen, that was a great comment in terms of, and it's a great suggestion that I can bring back. And again, my role is to be able to represent you guys, and that's why I'm here. Because in order to do that well, I need to kind of get feedback from as many of you as possible. And this, once we're done with this Facebook Live today, it'll be recorded. It'll be on our Facebook group. And then we'll be able to get your guys' feedback afterwards. Again, the day that I go in for that work group meeting, the first one, will be on the 23rd. So if you guys can have any particular suggestions, comments, questions, concerns that I can bring to the table, that's my goal. Is not just to provide my perspective as an individual, but to try and get as broad perspective of as many of you across the state so that I can represent you all you know, appropriately and accurately as much as possible. So, other questions or comments that you guys have? Or
and I think one thing that the developmental therapy community would be helpful for is when you come to this meeting, kind of let us know. And I think we also have trouble because one thing that we always get criticized about is not being specific enough in terms of our referrals.
Yeah.
So, you know, we'll say, oh, not using left hand as much or things like that. But, like, what can we do, especially, like I said, I think the things that we're talking about are kids who aren't showing delay yet.
Yeah.
Like, how should we document, or what do you need from us to better kind of prepare you to go into that home and, like, in anticipation of what you're going to find there.
Yeah. So that's a great thing for you guys to give some feedback, you know, so we can provide back to the medical community about, you know, what type of information will be helpful to get from our, you know, pediatricians and doctors so that we are best prepared to be able to kind of help them. I saw we got a couple other comments here. Let's see. Sorry I'm late joining. Hi, Chelsea. Isn't the group advocating for lead exposure being added to the medical diagnosis list of automatic eligibility? I believe that's the case, yeah. It would be one of the medical diagnoses. And then she asks, is there research that shows what we can do once a child is exposed that would mitigate impact the exposure later? You know, Chelsea, it's a great question, and we've been trying to kind of look at the literature, and there's a whole host of literature about the impact of lead exposure, but very, very little literature around kind of the type of things that can be done to affect or mitigate the effects. And so, like I said earlier, I think that, you know, it's an exciting time for us to be able to contribute to that work by doing this kind of, you know, making this an automatically eligible diagnosis, so that we can kind of try and see, you know, we could probably collect some data to kind of say, okay, we have a group of children who have not received service prior to this time, whenever we kind of determine it automatically eligible, and then we can start, maybe it'd be interesting to see if we can collect some data, if we can do good data collection of kind of saying, let's follow these kids long term after they've received some early intervention. Did what we do in early intervention for these children in comparison to those prior to us making you know, automatic eligibility for services? Did we make a change in these children's development? Were we able to mitigate some of those effects? And so again, I think what we do have a lot of research around is the value of what parents can do to help children kind of grow and develop, and how we can take advantage of all those early years and all the brain growth and development that's happening during that time. So I wonder if kind of taking from that information, applying it to these children, if we would be able to see, I think the possibilities are strong that we would be able to kind of mitigate some effects. But unfortunately, we don't have a lot of current data around it. Let's see. Kristen says, one more thought. We should make lead poisoning part of our dialogue with every family. That's a great suggestion. Ellen said, also, maybe the Early Intervention Clearinghouse can create or replicate a parent education handout. That's another great suggestion. I like this. See, we got some good ideas flowing here. The creative juices are bubbling. I am digging this. Susan said, excellent topic tonight. Chelsea, I believe you are correct regarding considering the auto-eligibility category. It's always wonderful to see medical community partnering with early intervention. Great job once again to the IDTA. All right, fist bump, man. We're doing some good work there. Is there primary impact on executive functioning? Yes, that is one of the things, right? They talk about executive functioning. Can you give any other insight on that?
Yeah, I think that's the area that we found the most prominent delays in terms of higher thinking, in terms of things like the skills needed to do math and just critical thinking. So I would say that is probably, but if you think about when you even see those delays, it's not till you're older. Like when do you start to really do critical thinking in school, or complex math problems, or reading comprehension? These are all things that happen much later, and I think that's why this is important. And I think this is a good time, like Benny was mentioning, because the one thing I think the crisis in Flint, Michigan did is it kind of brought lead exposure to the mainstream media. And I think that's important because it's so preventable. And I think, we have to talk about prevention. Ideally, we would be at a place where we didn't have to talk about this, where the number of children with lead toxicity was zero. And we wouldn't even have to talk about these issues. But that's not the case right now. And so right now it's trying to figure out what to do for these children. And then also trying to figure out ways to decrease that number.
Right. Yeah, I think I've also done some looking at executive functioning is a big topic, and I see a lot of children with autism, and there's also a lot of discussion about autism and executive functioning. At one of the conferences I was at a while ago, there was a great discussion, I think, from a lady from New York that did some talking about executive functioning. And I asked her how can we relate this back down to early intervention in the birth to 3 population. And again, we tend to kind of see those things and think about executive functioning at an older age, but like 0 to 3 has a lot of great information about some of the early experiences that eventually lead to good executive functioning. And again, I think that's the route that we can really help guide parents around, is what type of things do children need in these early years that lead to good critical thinking skills, right? Some of the exploration, the curiosity, some of the problem solving skills, and how do we foster that in children, right? And so I think that's where we as developmental therapists or as early interventionists can really contribute to making an impact on the eventual executive functioning of a child. Right. So we got responsive, consistent interaction. Seem like they may be the key. Right. 2-year-olds aren't usually matters of impulse control. Yeah, for real. Right. I was just talking with the early child care provider today, and I was on a home visit, I guess, or a child care visit, and I was talking to the teacher, and we were kind of reflecting about how the child with needs was doing in comparison to the other kids, and we're really reflecting on the fact that these kids, it's hard for any 2-year-old to have impulse control, and they said, and not to get anybody worried, but 3 is even worse, she was saying. So do you have a sense for how self-regulation figures into the picture? Yeah, I mean, I think that's a really big issue, I think, that we're seeing, or from some of the literature that you see with kids that have been lead poisoned.
Yeah, I think
it's like impulse control, and I mean, it depends on how you word it, but I think it's just kind of that, again, executive functioning, which is kind of contributes to like your inhibition, like understanding of, that isn't the right thing to do at this time, or that's a wise decision. And I think that relates to self-regulation. And I think that isn't just a day-to-day action in terms of, oh, should I go left or right, or should I do wrong or right? But even, should I apply to this for my future, or should I take on the certificate program, or is it beneficial for me to continue to stay in school? And so I think it's not just a day-to-day thing, but really has long-term implications.
Right. I think also, again, just thinking about typical 2-year-olds and that type of stuff, I mean, the prefrontal cortex, which is kind of the part that's really responsible for allowing children to kind of do critical thinking, and then the middle part of the brain, the midbrain, that really kind of does all the emotional kind of self-regulation piece. Those two parts are really underdeveloped still, and are really overridden by the base of the brain, which is all of the impulse, right? Like Dr. Harvey Karp's work that talks a little bit about, he describes them as little cavemen, right? And cavewomen, they just respond, and so, again, we're going to know that that's going to be an issue that's going to come up with children anyways. But we do know that there's a whole lot of different things through the responsive interactions of parents that can help children develop those self-regulation abilities, right? I often talk to parents about first creating co-regulation, because a child isn't able to do it by themselves, in these early years. But the parents have an enormous ability to be able to kind of calm, soothe, comfort, and provide that through that responsive interaction that you were talking about, Chelsea, earlier. We are able to get our kids to that place where the plethora of chemicals that are going through their brain during a tantrum, or those type of things, we're able to kind of soothe them with our own bodies, with the way that we talk and respond to them, that actually begins to kind of grow those parts of the brain that help contribute to self-regulation. So again, I think we have an excellent opportunity here as developmental therapists to help kind of have these type of conversations with parents, to educate them about the type of things that they can do to be able to help. Let's see, we got another comment here. Ellen, maybe the IDTA could jump on this campaign next October. And then there's a link here, EPA Gov Lead Poisoning Prevention Week 2016. All right, we'll look into it. Hey, Ted. Hey, Ted's coming in from Hawaii. I know Ted. Come and join us in the snow, Ted. Let's see, your description reminded me a bit of challenges children with FAS. Wondering if that is a place to explore possibility, supportive strategies. I think that'd be a great, fetal alcohol syndrome, to kind of look at some of those children as well. I think there's again, this is a great discussion. All this kind of sharing of ideas between all of us will help us kind of give some guidance, and I'm going to bring that up, and maybe we can kind of explore that route a little bit to kind of give us a little bit of suggestions of some of the things that we can do. Because again, this making the recommendation to make children automatically eligible is only going to be one piece of the puzzle, right? The next piece is going to be what do we do as interventionists to be able to prepare ourselves to kind of know how to tackle the situation, and finding other things like this fetal alcohol syndrome where we might have a little bit more information around can be very helpful. Amy says, as DTs, I feel we are also uniquely qualified to consider when it might be time to consult with or bring in another discipline to see if OT might be indicated or social work might be an important additional support. Yeah, it's a great suggestion. Again, because we as developmental therapists kind of think about things globally, I think we're going to be very, as Amy said, uniquely equipped to be able to kind of make those decisions of saying, okay, I think it's good to kind of bring this other person in that will be able to kind of help us. So I think we should be able to kind of get a general sense of what's happening with the child and provide a global perspective. Mm-hmm. And then as we start looking at some particular things that come up, drill down to kind of saying, hey, we need the input of this specialist or this specialty therapy to be able to help us with stuff. Absolutely. Hi, Jen. Welcome on. Other suggestions or comments or things that you were thinking about, Dr. Lee?
Yeah, I think that was a great suggestion because, and oftentimes it's the families. I mean, and the examples I'm using is from our clinic, which is one clinic, but it is on the south side of Chicago, and it's a lot of the same concerns that clinics have on the west side of Chicago. But it is often social work. I think is a great resource because it's trying to figure out again, like, why are they being exposed to lead, right? Because lead is an abnormal thing that we're not supposed to be exposed to.
Mm-hmm.
And so where are they getting that exposure? Where are they getting that consumption and toxicity? And I think a lot of times it's housing. And I think that's the biggest factor that we found. Housing, whether, again, it's paint or the pipes. And so then how do you find them resources to, because that's not within your realm of developmental therapist. How do you get them out of that environment? Because we can do all that we want, right? But if they live in the same environment or they're drinking the same water, then we're not getting anywhere.
Right.
So I think that's really a good point of it's not just what we're doing, which is important, but also getting children out of that environment.
Yeah. I think that'll bring a great discussion to that work group, to kind of consider that the support that from a social work standpoint to be able to kind of get the family the resources they may need to be able to kind of, make changes in their environment. Because you're right. I mean, if they're continuing to be exposed, no matter what you do, it's going to have little impact, right? Hey, Katie Joe, I see you're on. Thank you for coming. Other suggestions that you guys may have or things that we should consider, things that you want me to bring to the work group when I'm there on March 23rd. Please feel free to comment below or give us your likes or emojis. Or if we made you angry, I saw one angry face on there. I hope it was a typo. There's a like, But if we made you angry, that's okay too. I don't take things personally. I'll improve. Just let me know what to do to make it better. All right. But other comments, suggestions you guys have, given the discussion about lead and I know we've been on for just a little over an hour now, and I'm sure you guys are getting tired. It's been a long day of home visiting, and you guys want to get to some rest, relaxation, and wine, right? So if you guys have any other comments or questions, I'll give you a couple minutes to pop them in there. If not, we'll start wrapping up. Okay. Any final thoughts, Dr. Lee?
Yeah, no, first of all, I really thank you guys for everything that you guys do. I think the more that I go on with my career, the more I realize that, what we do as physicians is such a small part of all the services and things that children need and that children get through the medical system, and you guys are a big part of that. So, I think it's often a very thankless job, so I really appreciate what you guys are doing. And I think that it's through, events like this or discussions like this that I think we can better support each other's community, which is, I think, very important, because at the end of the day, we want kids to be better and we want kids to have productive lives and equal opportunity. And I think we can only do that by working together.
Absolutely. So I think that's a great takeaway for today, is kind of working together to kind of help improve outcomes for families. Chelsea, I saw your comment, and yes, we did talk a little bit about some of the other states, what we're recommending. You could probably, since it's recorded, you could probably go back and see some of those type of things. I think right now currently 15 states provide automatic eligibility, and I think most of them were 10 and above, right, at the level of 10 and above. But you should be able to find some information there beforehand. So well, in true EI fashion, we had some great takeaways that we had, and I'll ask you, like I tend to finish all my visits, Dr. Lee, if you had to pick 3 words to describe our time together today, what would it be?
Engaging, informative, and inspiring.
There you go. There you have it, guys. So, well, thanks everybody for being on. Hi from Hawaii, and we're glad to be working together on this, and I'll keep you guys posted, so feel free to this will be recorded, find it, we'll pin it on our Facebook group, and then give us your comments and suggestions when you guys watch it, and I'll bring all that stuff to the work group, and I'll keep you guys all posted and informed, all right? So thanks you guys all for being
Thank
on.
you.
Have a wonderful night.
Bye.
Take care.